wanna lose it. It's like a favorite song that we love to sing. Every time we hear the music, and we're in this love together.
Good morning.
Like the kind that lasts forever. We're in this love together. And like berries on the vine, it gets sweeter all the time.
Good morning, everyone. We are at the table this morning, and I have some of my favorite people with us today. First of all, I am Karen Dotson at the Medical College of Wisconsin. I'm a program director, and we are here today to sit at the table to talk about health-related topics. Good morning, Dr. Kevin Izzard. How you doing?
Good morning, Karen. So for those who aren't here, Karen's now.
Oh, Dr. Izzard, you're going to call me out every time, huh? Oh, wow. Well, no, I am virtual today, but I see you and Deb Nevels, who is program manager for cancer prevention from the Medical College of Wisconsin, is here joining us as well. She's at the table.
Yes, good morning, Karen. Good morning, Dr. Izzard. Thank you for opening the door and letting me in. I appreciate it always.
Dr. Izzard let you in this morning, Deb.
Yeah.
No, they said be careful who you let in, right?
Wrong. That's just wrong.
Wow. Every other Friday, we are so fortunate to be on the radio to talk to people about health-related topics and research. And Dr. Kevin Izzard, I know that you have been really looking at some information for us related to research and what's going on. So I'm going to turn it over to you this morning.
Yeah. Good morning. So all of us, our program really started off as trying to educate the community about the importance of being involved with research. There's a lot of studies, there's a lot of protocols, a lot of things, medications that come out, and they're being approved based on studies, scientific studies that are done, but we traditionally have not been included in those studies. And we thought it was important for us to be a part of those studies. My mantra is if you're not at the table, you're on the menu. And so if we're not part of those studies and they make recommendations, then the whatever the recommendations may or may not apply to us. So we really need to be part of those studies. And we know that there's certain things that African Americans are more prone to, or that we have a higher incidence of, or because of our genetics or whatever it is, because of our culture, because of our food, because of our lifestyle. Certain things may not apply to us, and so we think that we need to be part of those studies, and that's the whole purpose of the All of Us program. Well, the All of Us program really is a national program sponsored by the NIH, the National Institutes of Health, to try to set up a national database for researchers when they're looking at certain medications or looking at certain conditions. They can go into that database and they can pull from a number of people, including African Americans. And part of that initial drive was to get African Americans more involved in that, so they'd have a pool of African Americans that they could pull from. And so we've been encouraging people to sign up for that, because that way you could be contributing your information to scientific research. But anyway, so today I want to talk about some of the results of that, because people have been so gracious to to sign up for it, to enter their data. And some of it is just data like when you first enroll, we get things like your weight, your blood pressure, we get some lab work from you, looking at things like your blood count, and a metabolic panel looking at your electrolytes and saliva and urine, and that stuff gets stored. And then when someone needs that information, they can pull from it. And so, but
When
yeah,
you say they can pull from it, Dr. Izzard, they can pull the information like the data from it.
right, exactly right. They can
The
pull that.
data is analyzed. And so by it being analyzed, the researchers can go in and pull that data on the results of those different samples that were given, correct?
Even like genetic information. Now, and again, for all the stuff, we make it a big point that you have to consent to it. You have to understand how it's being used, and and then understand that that no one is going to contact you later on to say, okay, we're pulling this information. Once you give it, it's in the database and it's de-identified, meaning that it goes in with a number that no one is able to go back and identify you as given that sample. So it's really just a number of people that's all being gathered collectively. Um, and so, but yeah, there's even a genetic component to this. So they can look at at certain genes if they want to go back and again, you have to do a specific consent for that. To say we can use your genetic material. But yeah, so this has been going on for how long has this been going on now, Karen?
Wow, I think it's been about 7 years now that it's
Yes,
totally
it's been
when
a
it first
while. Yeah,
started.
so
Yeah, I've been around with it over
people.
5. Yeah.
Yeah.
Yeah. So, the thing about it that I really like about getting this research is that there's been a lot of research that has gone on in the past for African Americans that we weren't a part of. And so when they're basing medications and treatment, they're looking basically at like white male men as far as how they were able to get these results. And so it doesn't always work for us. And so that's why we want to make sure we have a diverse group. And so now Dr. Kevin Izzard's been able to see some of those results that's been happening by people donating their data, donating their samples. And so, Dr. Izzard, you want to share some of that with us today,
Yeah.
right?
And we're gonna. It's not these aren't just going to be from NIH studies. Some of these are going to be other studies, but I'm gonna get some just that's what kind of information is coming out. Scientific data that most of us aren't privy to because we're not looking at it. But there's some interesting stuff coming out, and we know things like, well, let's start with dementia. We know that, and we've talked about this on the show. We know that Black folks are twice as likely to have Alzheimer's, dementia. And when we say dementia, dementia is the bigger term. Alzheimer's is a type of dementia, but there are other types of things that cause um, dementia, Lewy body disorder, or things most of you never heard of. But the bottom line is that you develop dementias. Your brain, as you get older, it tends to be older people, your brain stops functioning in the sense that you have cognitive impairment. It affects your behavior in many cases. So what we used to call senility. And so now we know that Black folks are twice as likely to develop that. And why is that?
Right. Why
know,
is that?
right.
Yeah.
We might say, oh, maybe it's it's something genetic that's with Black folks. Maybe it has to do with how we're eating. Maybe it has to do with how we live. And so there's researchers looking at trying to figure out what that is. So I got a couple 3 studies looking at this at dementia. And so this first one is, and I'm going to explain a little bit about how these studies are done here. So this first one was done looking at blood pressure and how blood pressure relates to dementia. And so this was a Chinese study, the China Rural Hypertension Control Project. That's the name of the study. It was now this was an open label phase 3 trial. Now, open label means that that when they did the study, the people who were being studied knew they were being studied, and the people who were the researchers knew that they would knew what they were doing. So oftentimes we'll do these what they call blinded studies. So the researcher may not know who's getting the medication versus getting placebo, or the patient may not know if they're getting the medication or the placebo. This is a open label. So the people knew what they were getting.
So, Dr. Izzard, when you say placebo, can you explain to our audience what that means?
Placebo in layman's terms is sugar pill. So so the best kind of studies, and go back to maybe your first science class, you talked about the the scientific method. So the scientific method really is, you have an idea of something you observe, and you have this idea about, okay, what's going on here. You do a little research first, and then you come up with a hypothesis. So my hypothesis is that, in this case, maybe, okay, blood pressure is going to have an effect on dementia. Okay. Then you design a study, and then you study that thing, and then you evaluate it, and then you come up with a conclusion. And so, so the best studies are really ones where the person who's doing the study doesn't know which group the person is in, and the person receiving the treatment doesn't know what group they're in, because that way there's no bias, because there is such a thing as the placebo effect. And the placebo effect is this. Oftentimes when people believe they're getting something, it affects the outcome. And that's in all studies. So if you have a medication like antidepressant medications, as a good example, and most antidepressant medication studies, they have a group of people who get the medication, the antidepressant medication. You got people that get the placebo. They're usually called the control group, and oftentimes the control group will get better, and it's just because they believe that they're getting better.
We kind of talked about this last time, right? The psychological effect.
Psychological effect, right? But it even works with stuff like antibiotics. It works with. I remember in this big thing with the erectile dysfunction, when they looked at and did the original studies with sildenafil, which is Viagra, and they found that a lot. I think it was like 20% of the guys in the placebo group got better. The erectile dysfunction got better. So it's a very well-known effect. And so oftentimes they'll try to double blind the study. So they'll have pills in the control group, and the pill that you're studying will look exactly the same. So you can't tell by looking at the pill which one you're getting. And the people receiving the pill all have to take either the placebo, and they do the placebo and the pill of study at this, take it at the same time, do it the same way, so that the patients don't know. Only the people who know are the people who are the researcher. And so,
Dr. Kevin Israel, we have a caller on the line, and that's kind of early for us. So let's just see what the caller is saying, and then we're going to get back to your studies.
All right.
Good morning, caller. You at the table this morning?
Yes, good morning. Good morning. Good morning. Thank you
my buddy there, Tyrell.
Yes, it is. Good morning.
How you doing, man? Good morning.
Blessed and joyful, grateful, thanking the Lord. Good being in your presence. Good hearing from both of you. You, Kevin Israel, Dr. Kevin Israel, and Karen as well. Good morning. I've missed you. Haven't been on in a while, but I'm here. Good morning, Milwaukee. Good morning, Mr. Ryder. Good morning, Mr. Carvey. And yes, great day and great weekend to everyone. Well, I appreciate your research and everything and all the studies you're doing. I wanted to say, we're missing something here. I'm a Black Cherokee. I'm my mother's mother. Just about right off the tribal. I mean, the hair and everything. I mean, just a straight up Indian Cherokee woman. My mother too. But so I'm a Black Cherokee because my father, and my grandfather, both very tall Black men. But I'm a Black Cherokee. And I claim my heritage. But and I appreciate that. With the sickle cell, it seems like we're missing something because the different tribes, you can take the snake oil there and do wonderful things with it, And there were different remedies and things that we have really gotten, each tribe, I mean, the bones, the different things there that would be made into a serum and stuff there. So we've gotten away from a lot of the different things that the tribes have to offer us,
Yeah.
But as a Black Cherokee and as a Black man and a Black Indian, Black Cherokee, I just wanted to say, sickle cell, when we say we as Black people, well, I'm mixed. So I appreciate the Black aspect of it, but, what about the tribal? So, we need to be able to see if the tribes can help us with sickle cell and other things as well with some of these different remedies, whether it be, you don't want to do too much with the venom because that's going to kill you, but there's certain things that came off the scales of the snake and the rattler of the snake and different things, the fangs of the skin of the snake there that was a remedy,
Yeah. Well, that's actually a very good point because what happens with these drug companies as they try to discover new medications, what they'll do is they'll listen to those folk remedies and they'll say, oh, maybe it's something to it. And that's how they do the research. So they'll take the venom Okay,
Caucasian, right?
they'll try,
European,
right,
European point of view, right?
right, and they'll try to identify, okay, what in the venom is having that effect. They'll try to, and ultimately what they'll try to do is they'll try to put in a pill form or
Put in a
injection
tablet,
form
right?
that they can sell. Okay, but yeah, that's how they do. A lot of the stuff comes from the Amazon. They'll find these
Right.
different herbs
Yep.
and
Yep.
trees and insects and things that they can that they can use. And that's where our science comes from.
Yeah.
You
So
know,
I
and
had to
I'm
throw that in
talking-
there to give you, a different perspective to where, we're going at things from the European point of view and the Caucasian Anglo-Saxon to appeal and all this stuff. And it's not working. Even with the Oriental herbs and things, a lot of
Right.
those things work along with the tribal things as well.
Right.
Okay,
That's
great.
about money. That's about money
Yeah,
because
yeah,
again,
great weekend.
yeah.
Looking forward to meeting you all, and we'll talk again soon. Just wanted to give you a different perspective.
Okay, thank you for calling in and having that discussion with us. And I wanted to mention too that we do, and there are some Native Americans involved in our program. However, there's limitations right now as far as how we can really approach that population. And so we've been looking at how we can really get that population more involved as well. So I wanted to add that we are doing that because I know like a lot of times we think that and a lot of us have been told, and it has been shown through like the caller that we have some Native American in us as well. I thought I did, but I don't. And I was able to find that out through the study. I was like, and I'm still, I was in shock when I found out because that was always something we were told, but it didn't show it when I had the test done. So go ahead, Dr.
I think it's interesting too because because not my family, but I know my wife thought for sure that we got my great grandmother was Indian. Well, kind of find out she was. When because part of that study when you donate your genetic information is that they will look at your history, your genetic history, and they'll look at kind of like you do with Ancestry, Ancestry.com. They'll look at what part of the country your ancestors are from, or what part of the world your ancestors are from, and some of us are finding out surprising things. Maybe you didn't know you had some black in you, or maybe you thought you had something and you don't have it. And a lot of that kind of goes back to our history. We don't stuff gets lost along the way. So or someone said they were Indian, and maybe they meant like East Indian.
Yeah, I think there's a lot to
it.
Exactly. But let's kind of go back to what we were talking about earlier when you were mentioning about the studies, and you mentioned about this actually the blood pressure study related to dementia, but also you were talking about the phase 3. So this means that this is like the third phase of this study. Am I correct on that, Dr.?
Right, yeah. So usually the first phase is just to find out, is the medication safe? Can you give it to somebody and not kill them? And so they'll try different doses, and they'll try to see how it affects the person. Okay, and then they'll start looking at whether it's effective. Okay, and then that's when usually the phase 3 is when they're at the point where they're looking at at different groups and whether because to get approved by the FDA, a medication this has to prove that it's better than placebo. That's a very low bar, and a lot of medications can't even do that. They can't prove that they're better than placebo. So part of like what they did with like one of the big controversies with COVID when we were doing the vaccines was that they combined the phase 2 and phase 3 trials, and so they were still looking at the safety of it at the same time they were looking at the effectiveness of it. But yeah, usually they do that separately. They'll look at the medication safety separately from the effectiveness of it. But anyway, so this trial again, it was so when you look at these studies, you got to look at first of all, does it apply to me? No, so this is in China. So this is a part that's going to apply to African Americans in America. Maybe it will, maybe it won't. But that's a question you got to keep in the back of your mind. This study had 33,995 people. Okay, so fairly big. Some of these studies you might find might have 1,000 people or 100 people, or the smaller the number, the less likely that it's going to be something you can generalize to everybody. Okay, this was done in rural China. Again, rural area. It may be different than than us living in the city. And so what they looked at, the intervention aim was to get the blood pressure below 130 and the diastolic, the bottom number, under 80. Okay. And so the results during the 4-year study period, blood pressure was reduced by 20 over 9.3. So again, make that 140 down to 120, the 80 down to 70, 79, 71. In the intervention group compared with the usual care. The intervention group had a significantly lower incidence of all-cause dementia. Additionally, cognitive impairment without dementia was lower in the intervention group. Serious adverse events were less frequent in the intervention group. So, what is that saying? So that's saying that that in this study there was a positive correlation between blood pressure and dementia, and people who had blood pressure that was controlled had less dementia than people who did not have their blood pressure controlled. And that may not be something that's surprising to people. But again, unless you do the study to prove it, then it's hard to make these generalizations. Another study looking at dementia, and now they looked at all-cause dementia. So it looked at not just Alzheimer's, but everything else that might cause dementia. One that causes the dementia is what they call multi-infarct dementia. So people who have little, small, micro infarct, so blood clots in the brain. And people who
Ooh.
have high blood pressure are more likely to have that, or people who have dementia, or some people who have diabetes are more likely to have that. So again, anytime you affect the brain, you kill off brain cells, and so you're more likely to develop dementia afterwards. So again, that wasn't kind of a big surprise to people. There's another study
I
here.
have a quick question for you, Dr. Izzo, before you change the subject.
Mhm.
And, one thing, because African Americans, we really have challenges with our blood pressure. And a lot of
Mhm.
times that's hereditary, right?
Mhm.
Even though if we eat right, we do everything we're supposed to do, we still might end up with high blood pressure. So, your blood pressure, what you're saying is that if your blood pressure is really high, then it really affects your brain as far as how the blood circulates through the body.
Yep.
Is
So
that what I'm hearing there? So explain that to us a little bit
yeah,
more.
so high blood pressure, and a lot of us have high blood pressure. A lot of us have high blood pressure that's untreated. Um, and there's a reason why people call high blood pressure the silent killer, because most of us don't know our blood pressure is high. But the problem is that when it's high for too long, we talked about dementia. It can cause problems with your brain. It can cause problems with your heart. You can develop heart failure. You can cause problems with your kidneys because you got all that pressure going through your kidneys. So yeah, there's a whole lot of things that can come about from having uncontrolled high blood pressure, including increased risk for stroke. Um, that what and the whole point of doing studies like this is to kind of to prove that to make that point that it's important to treat the blood pressure.
We want to take a quick break and we're going to come back. We're at the table this morning this is Karen Dotson from the Medical College of Wisconsin, and I have Dr. Kevin Izzard with me, who is a family practice physician, and also Deb Nevels is joining us, and she is with cancer prevention. And so we're going to come back and have more conversation about research. We're also going to do some talk and some studies about cancer prevention and what's been happening with cancer as well. And that's one of Dale's specialty areas. And so we're asking that if you want to join the conversation and sit at the table with us today, you can call us at 414-444-5250, or you can call us at 414-444-5253. We'll see you back on the other side.
Table about research, and we had an interesting conversation going on during the break, and I'm gonna let my brother over here bring us up to speed.
Yes, sir. Yes, sir. So we was talking about chemo and things like that, and I asked the question: Is chemo the thing that's killing people, or is it the actual cancer?
Yeah. So he saw a video, and that's the thing that's interesting too. So he saw a video. Was it like on YouTube or
Yeah,
something?
yeah.
Yeah. You know, and then this person was saying, "Oh, it's not the cancer killing people. It's the, it's the chemo, it's the treatment that's killing people." And he asked, "Is that true?" Now I hadn't seen the video, so I can't really speak specifically to what he's saying, but it doesn't sound true. And usually I say this: if it doesn't sound true, if it sounds really far out there, do the research. Okay. Just
Yeah.
again, we live in an age now where it's easy to Google, and find out yourself, does this sound like something that's true or something that's not? Well, and then we got in a conversation about, just what is chemotherapy. So therapy basically is medication that you get that's killing cells. Okay. So if you got so cancers are rapidly growing cells that start off in one place and they end up someplace else. So if you have um, a all of us at some point or other will have a cell that for some reason doesn't work right and it keeps dividing. Okay. Normally your immune system realizes that and it'll destroy that cell.
Right.
So your immune system, your white blood cells see this rogue cell out there, they'll go in there, they'll destroy it and never cause the problem. Now, for some reason, if your immune system doesn't recognize that cell has a problem and the cell keeps dividing, and then it moves from where it's originally was supposed to be into another area, like it goes from your breast to your brain, well, guess what? Now you have metastatic cancer. Okay. And so the idea in the early days, we knew that these cells were growing and that and so the idea was, okay, this is going to kill you. Let's stop the cells that are growing fast. So they give you these what they call cytotoxic, meaning that they kill cells. They give you these cytotoxic drugs to kill rapidly growing cells. Well, the main one you're trying to hit is the cancer cells. But guess what? The cells in your intestines and your GI tract are rapidly growing. So you're killing those off too. And so when you kill off all those cells in your GI tract, guess what? You get nausea, you get diarrhea, you get vomiting. Okay. That's a side effect of the medication because you're killing those cells off too. Also, your skin cells, they're growing relatively quickly. So people, you know, about the people's skin will, they might get, the skin might get darker because again, you're killing off also normal cells as well as the cancer cells. Now, the whole idea, what we're trying to get to now with this precision medicine, and that's just another thing that's come out of what we're doing here with the research, is that now they can take the tumor. Okay. In fact, I was talking with one of my colleagues. His daughter, her daughter is doing a research project on this. They can take the cancer cells. So they do a biopsy. They get some of the cancer cells. They examine the cells, and there may be certain proteins on that cancer cell that normal cells don't have. And they can now make a medication that just targets those abnormal cells. They can prevent having to kill the normal cells. So and some of these, I saw one where they're actually are able to they can see the antigen. So they see this marker, this protein on the cancer cells. They can actually put this medication in. It attaches just to those to those proteins, okay, and then they can inject with another medication that now goes in and attaches to the medication that's attached to the cancer cells and kills it.
That's called
So
precision medicine, right?
medicine.
That's precision medicine, and that's what we've been trying to get to for years. And that's wonderful when you start hearing that they're doing that now.
Mm-hmm. Yeah, yeah. The problem though is it's going to be really expensive because you might have, again, this is a very not just breast cancer, but it's going to be a very specific breast cancer that has this very specific antigen on it. Okay, and so it's like some people have breast cancer might realize they talk about whether it's got estrogen receptors on it or if it has different receptors. So those different receptors determine what medication you can use to treat it, and so we're getting very, very specific. So they might be developing medication that might only benefit a couple thousand people a year. So the only way for the company to make the money back is to make this medication really expensive. And so that's the next phase that we're going to be dealing with is what do you do with these these very precise medications that only work for a limited number of people and they're going to be really expensive. Insurance companies are going to be dealing with that.
Mm-hmm.
So, but anyway, go ahead.
We have a caller on the line.
Good morning, caller. Thanks for joining us at the table.
Yes, good morning. My name is Angela.
Good morning, Angela.
Good morning,
Good
Angela.
morning, Dr. Izzard and ladies.
Good
So,
morning.
I went and had an MRI, because I have a bad back and I had a problem on my spine. So they found something on my spine and they told me Tuesday that it was cancer. So I cried all day Tuesday. But then I went to church Wednesday to the health class that we were taking, and they called me Wednesday and told me it was benign.
Amen.
So I shouted for joy. I was like,
Amen.
"Thank you, Jesus!"
Right? Amen.
Right. So now, now that that's cleared up, I also have to go back on the 16th because they found something on my brain that looks like cancer, but I'm not claiming that either. I'm not even finna cry because I know it's in God's hands and He gonna heal me.
Amen.
So but
yeah.
like my mom, she died from lung cancer. I have a brother now that's in the hospital. He has cancer, but it's like I don't, when I'm not, I thought about giving up. You know what I'm saying? Because that was something new to me. Because I'm like, I'm not ready. I ain't ready, but it ain't my faith. It's His faith.
Amen.
So I believe in the Lord, and I know He's a healer. Because look what He just did for me.
Amen.
I didn't lose the faith. I just, just had that moment.
Sister Angela, don't give up. In fact, we talked about
trust
this.
me.
Yeah.
I'm not.
The mind is so powerful.
So we talked about on Good Friday. We talked about the effect that faith has on your health.
Yeah.
And if we talk about the placebo effect, the placebo effect is about belief.
Yes.
So if you believe something works, even in a natural realm, just by believing affects your health. So
but I have
a positive attitude,
go ahead.
it helps you.
I have a question. Now, the doctor that I'm seeing, the doctor before was giving me shots in my back. Now, that made matters worse for me. So he's suggesting that he do the same thing, but like I told him, I'm not saying no, and I'm not saying yes either, but I'm trying to, maybe he can find something different to do besides the shot. So what do you think I should?
Yeah.
And then he's also talking about, like you said, doing a biopsy, but I'm not,
Yeah. It's scary, especially when you're talking about, taking something out of your spine. I get it. So the thing about your health is that it's your health. So you ultimately are the person responsible for your health. So, regardless of what anybody tells you to do, you make the ultimate decision. And so you can decide, no, I want to go try something different. Now, sometimes, doing that can cause, if it is a cancer, it may not respond to whatever alternative thing you try. So listen to, the people best advice I ever heard, is eat the fish and spit out the bones. So if someone tells you something, listen to what they're saying, but also, if it doesn't apply to you, you don't necessarily have to accept it. Don't go blindly,
You know what, Dr. Izzard, the other thing I want to mention too is that our caller is really doing what we need to do is get second opinions. And so she's calling, asking a professional, that's you, what are your thoughts? And the other thing that I wanted to mention to the caller too is that that's what we need to do. So a lot of times when you have questions that your doctor is telling you, seek other advice. Just get other opinions. Can you speak to that, Dr. Izzard?
Yeah, I mean, you hit it right in the head. You always have the right to get a second opinion. And so if they're saying that doing this injection might help, or taking this medication might help, or doing this biopsy might help, you can always see somebody else and say, okay, this is what someone I was told. What do you think? It also helps to have a good primary doctor, someone you can go to who knows you, and you can discuss these things. And they might say, oh, well, in my experience, it may not help. Or knowing you probably would not like this other treatment, or you might like this better. And so they can help guide you with some of that also. So hopefully you have a primary doctor that you can discuss this with, because I don't really know enough about the specifics and make and give you medical advice about it. But I will say generally it's better to get more information if you're not sure.
With that, my primary doctor that I did have, she did know everything about me. She's no longer my primary because they let her go. So I'm with a younger person that's like in her early 30s, just out the gate into the medical field. So she knows nothing about me. So I'm giving her a chance. But, I prefer older doctors, that's, like yourself, because I've heard of you and I've seen you before, but I never was your patient. So I'm just skeptical about certain things, and I don't really know what to do. So I don't want to take the shots because they didn't help me. They made matters worse. It really made me bedridden with those shots.
Yeah. It sounds like you should get a second opinion, and maybe consider something different. Yeah. If you need to take somebody with you, like maybe, where you go and you don't understand what they said, take, if you got a relative you want to take with you, or a pastor or somebody else to go to the visit with you, that's also helps too, especially when you're talking about cancer treatments and what the options are.
Yeah. Okay. And then too, Deb, I know that you probably have some information for her too, that there are support systems around for people that have, cancer diagnosis as well, right?
Yes, there are a lot of different, and please keep listening, because that's part of the second half of the show. We're going to talk a little bit about supports for those that have been diagnosed. But also, as Dr. Izzard and both Karen were saying, one of the things I tell people all the time is that doctors don't get upset if you decide to get a second opinion. There are ways that you can get second opinions, and they will get your medical records. They will look at it, and then give you other options that you may have. And if you tell them, this was my experience before, I don't feel comfortable with what happened before, they are able to tell you, well, this is the only treatment, or there are other options. So there's that, having that conversation. But I think also, as you were talking about this new doctor that you have, if you're not comfortable, just change, or just have that conversation with her and say, have you reviewed my file? Can we just take a moment to sit down and talk? One of the things, I mean, I love my primary care doctor, but one of the things I do also, my nurse practitioner is another person that I rely on heavily. If my doctor, I think I see my nurse practitioner more than I see my primary care doctor. Nothing personal against the primary care docs, but my nurse practitioner knows me just as well as my doctor. And she also has, sometimes she has more time. And so if the doctor changed, the nurse practitioner possibly didn't change.
Right, but this nurse practitioner she's new.
Okay.
And so I just met her one time. You
Okay.
know, my doctor got transferred to another hospital, but then they let her go from there all together. Not
Oh, wow.
because she was a bad doctor, and because she was a wonderful doctor. I loved her just like she was my sister.
Okay.
But so now that I got this young lady that's a nurse practitioner, you know, I'm just like, I'm 60. You're 33. I'm not getting. Don't get me wrong. There's nothing wrong with that. Trust and believe. But I get second opinions because when I had my cataract surgery, he messed me up. Like I'm an avid reader. My mother put a book in our hand. She didn't put us in front of the TV. So now I don't read as much because of my vision. Because he said, well, when I'm done with this, you're going to have 20/20, and I ain't got 20/20 nothing. I'm angry because he didn't do what he probably supposed to have did, and my vision I be seeing spots and foggy and all this, that, and the third. You know, it's not nothing that can be redone. It's over with. So I really depend on second and third opinions now.
Right. You know what? And again, take people if you're not understanding what's going on, take someone with you, who can take notes, and because a lot of times you hear something and by the time the 10-minute visit is over, they said so many things you can't remember what they said.
Yeah, when you're emotionally involved too. Yeah.
What surgery went? I had people come in. They say they had a surgery. What they do? I'm not sure. Who was the doctor? What's the doctor's name? I'm not sure. He was over at that other place. Well, he's not there anymore. It's hard. It's hard to hold people accountable if you don't know who it is and what they did.
Oh, I know who he is. I know where his office at.
Okay.
I can't spell his name, but I can say it real good.
Yeah. Yeah, because the cataract surgery that should have been a layup. That should have been pretty easy to do. And if you had a complication, I'd be curious, what happened there, because those are become very routine now. And you really have 20/20 vision after that.
Yeah.
Well,
sometimes there might be other things that can affect that too, right, Dr. Izzard? Depending on that person's health, if they have high blood pressure, if they're diabetic. I mean, there's a lot of different complications sometimes that affects your healing as well. And so, that's something that, caller, what I really suggest that you do is a couple things that, Dr. Izzard and Deb Nevels mentioned, is that you might want to take someone with you because that always helps. And also look for a second opinion, but have that conversation with whoever you're with. And say, whoever you've seen, I should say, and just say, like, did you really review my file? Can you go over it with me? What are your thoughts? I mean, have more details so you can get confidence that they have reviewed your file and that, you feel comfortable with who's treating you, because that's really key. You have to feel comfortable who's treating you in order for you to also get better results. And so thank you for calling today, caller.
And we'll be praying about you, having, with this, this second, possible tumor, that don't give up. Don't get frustrated.
Oh, trust me, I'm not. I am not doing that. Hey, listen, I got a lot of life to live.
Amen.
All right. Thank you for calling and sitting at the table with us today.
All right. Thank you guys very much, and God bless you all.
God bless you too.
Dr. Izzard, you mentioned about some other research. I know we're getting a little slow on time here, but yeah.
So the second project we're talking about was also looking at blood pressure. This one is what they call this is a longitudinal study of Black Americans at Wake Forest University and University of Georgia. They also looked at blood pressure. This was a bigger one. So this was a meta-analysis. So a meta-analysis means what they did was they took that study we talked about earlier, looking at that Chinese study. They take that Chinese study and they might take like maybe 10 other studies that also looked at blood pressure and dementia, and they combine all that data. So where the other one had 3,000 people, this one had 33,000 people. So it took a bunch of other patients. And so the more people, like I said, the more people you have in a study, the more relevance it has. And so they looked at this one here was actually looking at both the U.S. and China and Australia, and so a number of places all over the world. And they also found that there was a connection between blood pressure and dementia, which now gives more credence to that, because that one Chinese study, we said, well, maybe it doesn't apply to me, because they're Chinese. as opposed to Americans. This was a rural study. I live in a city, so maybe it didn't apply to me. It was a small number of people. Now we got one looking at, tens of thousands of people, and it's all over the world. So maybe that does apply to me. So that's how we get, we look at these studies and we try to decide, if it's relevant to us. Okay. There's another study here looking um, at um, discrimination. And
Yeah, well,
so
that was a very interesting study, Dr. Izzard, discrimination and how it affects our health.
racial discrimination increased the risk for dementia in later life. And this study here was done at the University of Georgia, okay, and it looked at Alzheimer's disease. And what they looked at was, um, they looked at three proteins that are found in that the brain makes, in people with Alzheimer's disease. And I won't go through the names of them because they're that's phosphorylated tau 181 protein, neurofibrillin light protein, and then glial fibrocystic acid protein. Long names, but let's take it. There were the three proteins they looked at, and what they found was that they looked at 255 Black Americans that were already in a study called the Family and Community Health Study. Okay, and they were watching these people over a number of years, and they looked at 17 years worth of data from these people that were in this study, and they looked at they questioned them about their experiences with racism. What they found was that there was no correlation. The average age was 56 years old. There was no 46. I'm sorry. There was no correlation between um, the proteins that they were making and racial discrimination at younger ages. However, people who reported experiencing discrimination in the 40s and 50s, though, they did have an increased production of two of those three proteins. And so they concluded that there is a correlation between the experience of discrimination in your middle age, so your 50s and 60s, as opposed to earlier. Now they had to do further studies to look at that, but that's an interesting finding. And you can see that some of the limits of these kind of studies is that, one, this is only 255 people, so it wasn't a big, a large group, and also it's hard to how do you study discrimination? So you can ask people questions about what you experience, and what one person experiences discrimination may not be what another person experiences. So there are limits, but there is a suggestion that racial discrimination might be contributing to dementia. And that's why we have a 2 times the incidence of dementia that white people do.
Wow. That's really interesting. We always talk about, why do African Americans suffer so much or have challenges compared to other races. And so, that's something that we always continue to have that discussion about. This is Karen Dotson. We're at the table today. I'm from the Medical College of Wisconsin. I have Dr. Kevin Izzard with me, who is a family practice physician, and Deb Nevels, who is program manager for cancer prevention at the Medical College as well. We're going to be right back to have more discussion and also really start diving into a little bit more about cancer and how there are support services for you out there. So please join us back. You can also call us at 414-444-5250 and 414-444-5253. I look forward to talking to you on the other side.
We are back, and I got a couple of things I want to get done before I leave here. You are, if you're just tuning in, this is all of us, um, and at the table,
At
and
the table.
I'm here with Karen Dotson, who's my partner in crime here in
That's right. That's right. Definitely.
Wisconsin, and we are talking about research and your health and how it applies to you and to the treatment that you get. I got a couple, and I'm talking about some of these studies that have come out of the research that we've been doing. I got a couple of ones that I want to get to because I know we got a guest coming in at 8 o'clock in a couple of minutes. One of them is about antibiotic use in early childhood because
Yeah.
these are things that are that are kind of relevant to to us, especially if you have small kids. So
Mhm.
a lot of times you take your child to the doctor because they're pulling at their ear, they got a cold, they got an ear infection, and you go in there expecting to get antibiotics because they have an ear infection. Well, this study this was a retrospective cohort study looking at 1 million children. So they took, so this retrospective cohort, they went back and looked at records. Okay. And they looked at a million kids, 1,091,000 kids that were exposed to antibiotics before the age of 2. And what they found was that kids that have antibiotics before the age of 2 are more likely to develop problems with asthma, food allergies, and allergic rhinitis. Basically, sinus stuff. So, um, and I won't go into all the details of it, but suffice it to say that in Canada and in Europe, they are far less likely to treat kids with ear infections with antibiotics because usually the child has a cold, and then once that cold goes away, the ear will clear up. There's a tube behind the ear called the eustachian tube that gets blocked. When that gets blocked, you get fluid that builds up behind the ears, and bacteria starts to grow in there, or the virus from the cold spreads up, through that eustachian tube into the ear, and they get an infection. In most cases, that ear infection will clear up once the cold goes away. Now, because kids get a lot of colds, because again, they put things in their mouth, they don't wash their hands, they're more prone to getting colds. And so because they have such frequent colds, they will get a lot of ear infections. And then also because of the shape of their ear, the shape of their head, and that size of the eustachian tube, it's more likely to get blocked when they're kids versus when they're adults. Um, but again, suffice to say, in most cases, that ear infection is going to clear up without antibiotics. The only time it really becomes an issue is if one, it doesn't clear up, so you got a resistant bacteria growing on or something, and two, at that age, usually at a young age, 2 years old, they're developing speech. And if they can't hear, it affects their ability to speak, to learn how to speak. So they will put if you can't get that ear to drain after the cold's gone, then what they'll do is they'll put tubes in their ear. And I put tubes in quotations because what they do is basically they put a hole in the eardrum. If they can't get that fluid to drain back through that eustachian tube into the nose where it's supposed to go, then they'll put a hole in the eardrum and the fluid is drained out into the ear canal. And so bottom line of this study right here, think twice about getting your kids antibiotics for ear infections because that's
You know,
usually
that was so interesting when I read that article, as far as when it relates to children and antibiotics, because I always thought that, give the kid antibiotics is a good thing.
Mhm.
And just about, we used to really think that for us as well. And doctors are more hesitant about adults getting antibiotics too
Right,
because of the
right,
resistance, right?
right, resistance, and the other problem is this, and this is something that a lot of people are probably going to laugh at, but dirt is good. When you're young, your immune system is still developing. So when you're exposed to something at a young age, your immune system is more likely to say, "Okay, I don't know what this is. We're going to be tolerant of this." So later on in life, when you see it again, you're not going to overreact to it. And what we're finding is that a lot of kids now that are growing up in these super clean environments who aren't exposed to as much dirt, that they are more likely to develop allergies later on because their immune system never got exposed to that stuff. And so, we used to eat off the ground and stuff like that, and you kind of laugh about it, but eating off the ground isn't necessarily bad. you know,
Well, listen, as long as we
if
don't
God
eat too
made
much
dirt,
of it,
dirt
right?
don't hurt. Or you get the 5-second rule. Yeah,
Yeah, the 5-second rule, right? Yeah, I heard about that. Dr. Izzard, I was just looking at on the chat. Someone mentioned they said that if you had a family doctor and they leave, but you aren't assigned a new one, will the NP nurse practitioner do? Well, that is that
Um, I,
suffice?
I tell you that is something that's definitely evolving right now. So a lot of places are hiring because it's hard to find doctors, primary care doctors now, that they are hiring a lot more of nurse practitioners to do the work. So NPs and physician assistants have to have a collaborator. So they have to have a doctor that they're collaborating with. So you might have one or two doctors in the office, and you might have 3 or 4 nurse practitioners. So they can do most of the regular stuff, follow up your blood pressure, follow up your diabetes, colds, that kind of stuff, and then they'll use they'll leave the complicated stuff to the actual physician. Um, and I would say in a lot of cases, unless you got unless you have a really complicated medical history, I would say in most cases the nurse practitioner is, I won't say that's not just good enough, but a lot of times, like Deb was saying, they have more time to spend with you, and because they're trained as nurses, a lot of times they may be maybe more sensitive to your needs than the physician might be.
Dr. Izzard, can you explain to us the difference between a regular, I'm not going to say a regular nurse, but a nurse and a nurse practitioner? What's the difference?
So the nurse practitioner basically is they have a nursing degree, so they're nurses, but they go on to do further training. So it's not as much training as a physician does, but they do further training, learning clinical skills. So they learn how to treat. And in Wisconsin, they're licensed to practice medicine. So they can prescribe medications, they can order tests, they can do all most of the things that your primary care doctor can do. But they don't have as much training, and they have to have a collaborating doctor who kind of basically supervises their charts and reviews their charts and things like that, and who they can go to if they have a question. So yeah, for most cases they can write prescriptions and everything else.
So that's nice to know. But also, the final say is through the doctor, though. And I think that's what people really need to make sure that those nurse practitioners definitely have to consult with the doctor as well. And
Right.
then doctors have to review your chart eventually as well.
Right. So you might either have a nurse practitioner, again, who they start off as a nurse and they got an advanced degree in nursing, or maybe a physician assistant, and that program is basically doing the same thing. Only thing, they're coming from a different point of view. So they're coming as a program just training them to be a PA, a physician assistant. Even though they kind of do the same things in the end, the nurses kind of come from a nursing point of view, and the PAs come more from a traditional medicine point of view.
Thank you. Dr. Izzard, I know that time is getting short for you as well.
Yep.
But Deb has a special guest that she has invited to have more conversation with us today. And Deb, can you introduce our guest for today?
I would love to. And my understanding is that she brought the peach cobbler to the table. Am I right, Keisha? Did you bring the peach cobbler to the table?
I would love peach cobbler this morning.
Me too. I'm like, ooh, for breakfast?
I know he had it for breakfast.
We're having it for breakfast.
Well, it has fruit in it. It's healthy a little bit.
There you go. That's what my mother would say. That's what my mama would say. So, family, today we are so blessed. We are so blessed. We have Miss Keisha Jones with us today. And I have to tell you, I owe her big time, because last night she and the team at ABCD, or After Breast Cancer Diagnosis, they had a huge gala. And so she is coming off of that. And I am so appreciative that she took the time. So yes, Keisha, I know I owe you big for getting up early in the morning to come and join us at the table. But let me introduce my friend, dear friend to you all. Keisha is the Director of Healthcare and Community Partnerships at ABCD, which is After Breast Cancer Diagnosis. She is also the president of Sisters Network of Southeastern Wisconsin, which is a group of incredible women, of which I'm honored to just sit at the hem of their garment. that are breast cancer survivors and thrivers, who every time we meet, it's just a meeting of business and then foolishness because they all make us laugh. They have so much fun when we get together and do good work. And Keisha's going to join us today to talk a little bit about the work of ABCD, to tell us a little bit about the party last night and the good work that they did last night, but also to share with us a little bit about Sisters Network. Um, and she's just pulled a chair up to the table, Karen. I'm just glad.
Yeah, Keisha, I want to welcome you for coming and sitting at the table with us today. But I also wanted to ask you, why do you have such a focus for the work that you're doing? What has caused you to want to do this work, Keisha?
Thank you. And thank you, Karen. Thank you, Deb, for inviting me in, of course, for Deb Neville. Sorry I couldn't be right there in person, but coming off, as Deb said, we had a gala for ABCD last night. I think we left there maybe, well, I know it was a little after midnight, but I am with you ladies this morning in the community. I think my connection and passion for...
Keisha, I'm going to stop you for just a quick second. Do you have us on speaker?
Oh, yes. Let me take you off.
Yep,
Can
because
you hear me now?
feel choppy. Yeah, I think that's better.
Yeah,
sorry.
thank you.
Better?
Yes, that is much better. I'm sorry.
Okay.
Please keep going.
No, yes, no, but thank you for inviting me to the table. And my passion for this work, definitely, I think I've always had a passion for women, whether it was young adults, in high school, in college, just making sure to mentor them, to know that they can achieve their dreams and that they can have support to learn the things that they need to be successful in life and to be proud of who they are. But after my personal breast cancer diagnosis in 2018, that really just shifted everything more for me towards advocating for our health and just making sure that we get our mammograms, that we know if we are at risk for diabetes, high blood pressure, whatever those health diagnoses may be, and symptoms, that we don't ignore, and that we know our family history. So just after that personal diagnosis with early stage breast cancer in 2018, and then later a reoccurrence in 2023 to stage 4 metastatic breast cancer, it's just been really laid on my heart to give back in a way that just helps other women learn information so that they know their bodies and they can advocate for themselves.
Awesome. And Keisha, part of what I wanted you to come to the table to talk about is the importance of, and we talked about it a little bit earlier, of having support. And I know between Sisters Network and ABCD, the supports that women have, or that anyone who's going through that journey, that's offered through those two programs specifically, is so critical and so important. Can you share with us a little bit about what ABCD does and the support that they offer for individuals that are going through a breast cancer journey?
Yes, ABCD, after breast cancer diagnosis, we're celebrating 26 years this year as a nonprofit organization right here in the community that provides free emotional support. We train breast cancer survivors virtually to become a mentor to someone that's either newly diagnosed, or they could be 2 years out, 5 years out. Anyone that just feels like, hey, I want to talk to someone that's been through this. Sure, we can talk to, a family member, a sister friend, someone from your church, an auntie, to get support. But being able to be matched with a mentor that can provide that one-to-one emotional support and that connection around the person that you're talking to on the phone had the same type of chemo that you're about to have or that you received. they had the same type of surgery. They have a similar stage in life in terms of we're going to match you with, if faith is important to you, match you with a mentor that had the same type of surgery and breast cancer as yourself, but also someone who is a mom, who is vegan, who shares the same type of faith, who may have children the same age as your children when you were diagnosed. So for me personally, I've probably mentored over 15 women here in the state of Wisconsin and in other states. And it's always just that genuine connection, because now I'm able to talk to someone and share a little of my breast cancer journey, and it helps answer questions for them. It also just gives them relief that, you know what, I'm not alone and I can get through this. So they can ask questions of the mentor about, what does radiation feel like? How did you feel after chemo? And how did you handle those side effects? And sure, you can get that information from your healthcare professional, your doctor, your nurse, and again, talking to that support system that you build with your family. But there really is nothing that can compare to talking to somebody that actually went through it, so that you can really just connect and bond around this diagnosis, which is, it's life altering, right? It's shaking up your day to day, everything that you thought or envisioned for your future. Now it's like on pause, and being able to talk to someone that went through that it's so valuable.
Keisha, what you mentioned is so key, because when you're going through something, if you haven't been through it, it's not the same. And you always think like, oh, I can imagine, and you really can't imagine until you go through something. And so that what you're doing is so important for people to be able to talk to someone that's actually have gone through it and know what to expect and can help them walk through that process. So, I really commend you for doing that. Even with your challenges, you are still helping others as well.
Right. And it's I think for a lot of people that decide to become mentors for us, I mean, it's that same willingness to give back so that no one has to go through it alone. So it's just like this for me. It's, once you get through your journey and you get through your surgeries and chemo treatments, it's like the light comes on and it's like, gosh, I really want to share my story. I want to make sure that, other women in my community are getting those mammograms and that they're doing self-checks, that they're just aware of their body and they're not ignoring their own health, with the busyness that comes with, being a mom, being working outside the home, being a woman, in the community and involved in church and so many things. So I think it just immediately, once you go through this, it's just this desire, oh gosh, this was so heavy. How can I share what I've learned along my journey with someone else? So right now we have over 270 mentors. I would say half are in the state of Wisconsin and half live in other areas, but they are able to connect over the phone and just help walk someone else and answer questions and be that listening, empathetic ear.
So when people are, and I want you to be able to give this number out more than one time, because people are listening and then they, have to leave the radio for whatever reason, if they out of their car or whatever. But I wanted to ask you, can you share the number of how people can reach and contact you or individuals that can give them that support?
Yes. So if someone has been diagnosed with breast cancer and they would like to be matched with a mentor, they could reach us by calling 1-800-977-4121. That's 1-800-977-4121. And if someone wants to go to our website, we do have a short maybe take a couple minutes to fill out a form to get matched with a mentor. And our website for that, with the ABCD letters, is just ABCD breast cancer support.org. And so once you get to our website, you can see a form in order to get matched. And then our goal is within 48 hours to give you a call to see how we can get more information about your medical history and who you are as a person, right? Because you are more than the cancer diagnosis. And then we'll look to see which one of our mentors would be a good fit to start that mentoring journey.
So do you also have group sessions for people too?
We don't have like a support group through ABCD. What we do is just the one-to-one mentoring, so connecting them with a person. We do have some of our other like partners that might offer a support group. So if someone reaches out to us for that one-to-one match, and then they need additional info about like local support groups, then we can refer them to some of those local support groups.
Great. So you're just a wealth of resources for people that are challenged with, with cancer and breast cancer, especially. Wanted to ask you a question related to, what about people maybe that skip going to get a mammogram? Like I know every year we should go get one, but sometimes people skip. And I was a little late with mine, and I was getting a little worried. As much as I do these shows, I was like, oh, I was a little late. I was more than a year. And my staff was like, hey, you need to go. And I was like, yeah. Then you get a little scared, like, oh, what if? But what can you say for people, about mammograms that are so important and key for them?
I know that sometimes there can be a fear, and sometimes it's the fear of the unknown. If it's going to be their first one, or like you just stated, you get busy, life happens, and then you realize, hey, I skipped it this year. I have heard stories, I'm sure Deb has as well, of, women who have missed a couple years. I think just recently, Tina Knowles, she shared her story. So there are women who will miss, and then, sometimes you can go in and it could be, it could have been caught at an earlier stage if you were more routine. So I think it's just so crucial for women to, just like we celebrate our birthdays and anniversaries, a girls' trip, like make the mammogram a priority in your life so that you are getting that screening done. And if you realize you missed it, then immediately that's your opportunity to correct, right, and get it scheduled, because the earlier it can be caught, the better, so that you are not, so that it doesn't advance. So it's just important for us to hold our sisters accountable. The month of October, you see so much about breast cancer and mammograms, but really with a lot of advocacy groups and support groups, our goal is to have this in front of you throughout the year. So, don't wait till October. October, you're going to see, pink everywhere and hear about it. But throughout the year, education and awareness and that outreach is so crucial because if it is caught early, you can have a better chance with outcomes for treatment.
One thing that you mentioned, well, a couple of things. You mentioned just don't wait for October, but celebrate on your birthday. I like that. Like, what can I do for my birthday for me? And that's what you were just saying, like, for your birthday, think about those things, Keisha. Isn't that what you just mentioned?
Yes, if you're, how we celebrate our birthday, us, the family, we going all out, give me the bling, the food. I'm planning, it's all day, it's all weekend, it's all month, right?
Yes.
So, do put that same focus on our health. So, mark a day, whatever your annual mammogram date should be, make that a party, make that a celebration. You're going to, treat yourself. When I think about my own journey and now my monthly appointments that I have for my treatment, I guess I'm still making Starbucks rich because after all of my appointments, it could be a 3 hour, 4 hour appointment, and that's my treat. I'm going to Starbucks. I'm getting a favorite drink, maybe that lemon cake. So it's just important that we make our health a priority. So, however we have to do it, if we have to tie it to a certain date, just make sure that we get it done. And if we need a sister to support us, if there's an opportunity to schedule it around the same time, or just, okay, now we're going to have lunch. You got your mammogram, I got mine this week. Now we're going to go just, celebrate good results, right? So that we can just be connected and be there for one another.
I just wanted to let our audience know that you can call and talk with us today and come and sit at the table with us. You can call 414-444-5253 or 414-444-5250 to reach us and to talk with us, and also to talk with Keisha Jones, who is the Director of Healthcare for Community Partnerships at ABCD, and also a cancer survivor. And, Keisha, just talking with you is very encouraging because not only are you challenged with your health, but you also are continuing to help other people in this journey. So you're taking us along with you in your journey. And that says a lot about your character and how do you keep your mindset to be able to do all these things, Keisha?
That is a great question, Karen. There's balance. In fact, usually people will say like, "Oh, we see you here, there, everywhere." I said, hey, I can be where it's Waldo, whatever you need. It's important to me. I think I've always just had instilled in me a desire to want to help and support my community, and I just find that balance. And of course, my faith keeps me grounded and where I need to be. But that balance, just putting myself first. Sometimes I say no, or not right now, or how can we make this schedule work? Or I'll have a busy weekend, and then that next weekend, it's like I'm a couch potato.
Mhm. Taking time for yourself too, making you priority is key. This is Karen Dotson from the Medical College of Wisconsin, along with Deb Nevels, who is also from the Medical College of Wisconsin in cancer prevention. We're joined with Keisha Jones, who is the Director of Healthcare for Community Partnerships at ABCD after breast cancer diagnosis. We're going to take a quick break and we'll see you back on the other side. Please join us at the table.
we hear the music and feeling this
Welcome
love
back,
together.
welcome back, welcome back.
Yes, welcome back, everyone. This is Karen Dotson at the table this morning with Deb Nevels from the Medical College of Wisconsin, and we have our special guest with us, Keisha Jones, the Director of Healthcare and Community Partnerships at ABCD After Breast Cancer Diagnosis. She is a survivor, and also she works in the community so hard, and Deb has really partnered with her on several occasions and calls on her. And they had a big event, a fundraiser last night as well. And Keisha, when you have those fundraisers, what exactly do you do with those resources once you get those?
Yes, that is a great question. And we have an amazing team at ABCD with Ellen, our executive director, and Ashley, our director of corporate marketing and events and corporate sponsorships and events. And she puts on just an awesome event for the community to come out and support. And then all the funds raised, we're able to use for our training, for, resources that we send out. So our virtual training, we do about 6 to 7 trainings throughout the year where we train mentors. It could be anywhere from 15 to 25 mentors, volunteers that are logged in. We do specialized trainings, so funding is used for that. So whether we're training, we actually just did a training April 30th, Wednesday night. We did a training virtually for metastatic breast cancer patients. And then we do a training for early stage, so anyone stage 1 to stage 3. And we do male breast cancer trainings because obviously men also can be diagnosed with breast cancer. So we do have some men that are mentors for us as well. And then we do pre-Viver training. So those are trainings for someone that genetically is predisposed to breast cancer. Maybe they're already carrying a gene, so the BRCA gene, or they know at some point they will be diagnosed with breast cancer. And so we have some women who have gone through our training to be able to be a mentor to someone that calls in that regard. So any funds, anytime someone donates to us, we're able to use that funding so that we can, be in the community to ask women to be in these places, to work with healthcare professionals to make sure they know about the services we offer. And we can send out our brochures and resource information that they put into folders for someone that's newly diagnosed. And so they share our materials and we don't charge them to receive our material. So just any funding that we receive, it allows us to do this important work. We also do virtual webinars. We do about 6 a year on different topics where I think we have one coming up in May that's going to be on breast cancer clinical trials. We did one in March on parenting a young child through a cancer diagnosis. We've done it on lymphedema, on emotional self-care. So all of this funding just helps us continue our mission of making sure that no one should go through this diagnosis alone.
Wow, that's significant as far as the resources that you provide for individuals. But Keisha, one thing that you mentioned that I thought was so interesting and very concerning too is that when you say that you have a gene and you eventually will be getting cancer, can you speak a little bit more to that for people?
Yes, and I'll preface it by saying, obviously, I am not a healthcare professional or expert, but just from my understanding and just the research and the materials, the outreach that we do, And I'll say this is from a lens of probably under the Sisters Network more so, just with knowing if someone, I'll just use BRCA as an example, when you're diagnosed with breast cancer, and for me personally, once you're diagnosed, that is testing that they offer to see if you carry this gene that is could be an additional factor in why you have been diagnosed with breast cancer. So a lot of times when someone is diagnosed, I was negative for that BRCA gene. So my cancer was driven by other factors. But for someone that takes this test and now they know that they're positive for the BRCA gene, then it's most likely a matter of when they might fully be diagnosed with breast cancer. So for them, they then need to make decisions. Do they just continue maintenance therapy, meaning, do they just have the doctor watch to see what happens, or do they go ahead and make a decision, to have a surgery or have treatment to prevent before it comes. So, and Deb could probably also add to that as well. But it's definitely important knowing the family history, being able to have access to testing, because there are other genetic mutations, or there's other genetic mutations, but just other cell mutations in general that could drive cancer. And so some of those other cell mutations may not be hereditary. And so it's just important to know what type of cancer you have so that you can get that targeted, treatment specific to the type of cancer that you have.
Keisha, you mentioned something that Deb is shaking her head on. So, Deb, I want you to elaborate a little bit more on this, please.
Yeah, it's that family history piece, and I say time and time again, and everybody at the table, it's the secrets that kill. And so the important thing is to know that family history, because one of the things, and Dr. Izzard would probably co-sign this for me, when you go into the doctor and you're advocating for yourself, it's important to be properly armed, if you will. And part of that armor that you bring in is knowing what your family health history is. So being able to say, my brother or and my dad, they both had this kind of cancer. My mother and my sister had this type of cancer. That gives your doctor additional information that they can then justify things such as genetic testing, earlier testing, the things that we talk about putting you in a higher risk level is that family history. And so, and then Karen, you and I were talking earlier about with Dr. Izzard about that precision medicine, for us to be able, for doctors to be able to be proactive and to be able to prescribe medicines more precisely. Being able to identify the family history helps them to better treat the patient. And so having that family history can also help to determine, okay, well, my mom had breast cancer. She did have that BRCA gene. So what should I do? And then your doctor can say, well, you know what, we're gonna go ahead and get you tested, genetic testing. And then I'm gonna start your mammograms a little bit earlier. And then I want you to do some self-exams at home, but we're going to gather this baseline information in an early mammogram and genetic testing for you. So this gives you the information, and this information is critical because if you don't have it, and you want these tests, you would have to sometimes pay out of pocket. And with your doctor being able to say, no, it's medically necessary because of this, your insurance company would be more likely to cover it. So being able to walk in with that is really, really important. One thing, Karen, I want to back up, and I think um, uh, Keisha is not giving ABCD all of the credit that it's due, and she slipped it in a little bit.
Okay, so she's holding back a little bit there.
She slipped it in a little bit. Yes, she did. um, Keisha, it's now ABCD started here in Milwaukee, in Wisconsin,
Mhm.
but
Mhm.
now you're in. Do you know how many states? Because it's grown.
Yes. So we started, Melody Wilson-Oldenburg started the organization after her own breast cancer diagnosis. And so founded and grounded here in the Milwaukee area. And we are probably, I don't think we are quite in all 50 states, but we do have mentors. I want to say maybe in about over 40 states. Mentors that have trained with us virtually. And so now they're able to be matched. So, a mentor could be matched by location. They could be matched. I've mentored people in Texas, in Atlanta, California, like wherever they are. It's basically that matching process, is driven by, are you the best person in terms of sharing those medical similarities in addition to who you are as a person. So we have grown. Her vision was to continue to obviously have the services for free, and started out with a group here in the Milwaukee area. But over time, we've really just elevated our outreach and impact by going to, definitely within our homes, our hometown, home area, local conferences and health fairs and community outreach events. But nationally, we travel, and especially in my role, traveling to national healthcare conferences and other conferences that nonprofit organizations offer, so that we can continue to just spread the word about the resource that we have. And so we've been able to partner with a lot of local and national organizations and healthcare professionals that also want to utilize our services, and so that just continues to broaden our reach, which is just amazing.
And that's why that 1-800 number is so critical. And again, that
Mhm.
number, and that's why I want everybody who's at the table to know this number, because if you have friend, family member in another state, just because we're here in Milwaukee does not mean that your friend or family member down in Mississippi, in
Right.
Florida, in California cannot access these services. And again, that number that they can call to be matched is 800-977-4121. And
Say
then,
that again, Deb. Let's make sure people can get
yeah,
that.
please, everybody get your pens and pencils.
That's right.
It's 800-977-4121. And that's for ABCD to get matched with someone, a mentor who can help you during your cancer journey.
Mhm.
The other
Deb, go
I want
ahead.
we
I'm sorry.
is Sisters Network.
Okay.
Um, Sisters Network that Keisha is the president of the Southeast Wisconsin chapter. And I love Sisters Network just because we do work, and they work me hard, Karen. I gotta tell you, they work me hard. I
But I
do
mean, it's for a good cause, Deb. So
it for
you just gotta, you can't turn it down.
no, I know I can, and I better not. But I do, as I'm voluntold, as I like to say, Sisters
Voluntold. Okay.
Network. Keisha, if you could talk a little bit about that work that you do, and like you said, she is busy. She is busy.
And thankfully, I have a wonderful team of dedicated um, uh, members like Deb, like Dr. Underwood. I think that's our voluntold. She already was texting me this morning about something, so that's next on my list. But just a wonderful, dedicated group. And Deb does so much. So Deb is underselling herself as well. The work that she does for just the community at large, Karen, you see it. She's touched so many, and just her support of Sisters Network, of so many of us in the community through MCW is phenomenal. So I thank you for all that you do. So there is no way I wasn't showing up. I couldn't show up in person, but there's no way I wasn't going to wake up and be ready, because Deb has. So thank you. But Sisters Network, we are a support group made up of breast cancer survivors, and our associate members who are nurses, doctors, they were caregivers. They're just women who care about our health, care about awareness around breast cancer. And so we started out in December of 2020. So after my diagnosis, I just really, again, wanted to give back. So just looked for a way. I didn't really want to start my own nonprofit. So I had found out about Sisters Network and actually had known about them when it was a group here, Sisters Network of Milwaukee. Before I was ever diagnosed with breast cancer, I knew about them, and that group turned into a different group. So I was aware of the national organization. And so once it touched me personally, I was like, I think I want to start this here in the Kenosha-Racine area, but also extend that back into Milwaukee since people were familiar with the organization. And we currently have over 50 members. I would say half of them are breast cancer survivors. The other half, again, those supporters who rally with us and do so much amazing work. We're able to do breast cancer walks in our local communities. We do a big health and resource fair called She Day, which She stands for Sisters Health Empowered, where we're able to bring in like a survivors panel and a healthcare professionals panel. Deb, I think, was our moderator for that last year, and we received support from NCW and their team. So everything kind of like the party with a purpose. I think that was Tom Joyner. So I kind of feel that anytime we have a program, we want it to be fun, but we want to, while we have you in the room, we want to give you education and resources that you can use to improve your life, to improve your health outcomes. So any of the programming that we have, whether it's a virtual webinar, we want to make sure that, yes, it's going to be fun. We want you to show up, look cute, give out some swag, have a good time, some good food. But we're going to have some type of medical presentation, some type of story from one of our members that's a survivor. We really just want to empower you while we have your attention. And Sisters Network nationally, they have over 30 chapters in different states. So if you are in our area, Sisters Network Southeast Wisconsin, we help women in Northern Illinois, and then Kenosha, Racine, and Milwaukee counties. We do have some financial support. We have a Facebook page for Sisters Network of Southeast Wisconsin. If you were at you can look up Sisters Network Southeast Wisconsin for the Facebook page, but our national organization, their website is sistersnetworkinc.org, and they, a couple times throughout the year, they have a financial assistance fund. So we just really, the connection for all of us that are in this group is just that opportunity to show up. We go into churches, we go to community health fairs, however we can bring awareness all throughout the year, not just through the month of October, to make sure that women are advocating for their health and getting those early mammograms is what we're working towards every day.
Keisha, this has been a joy to have you on our show today. And for those that are listening, Keisha Jones, Director of Healthcare for Community Partnerships, ABCD, after breast cancer diagnosis. I want to thank you for joining us at the table today. I want to thank Deb for bringing you in and for being committed to, after your big event last night, coming and sitting down at the table with us to reach out to our audience and talk with them about the importance of breast cancer and how they can have that support that's needed. And so we're going to get ready to close for today, conclude for today. We're going to still have more great conversation at the table in the next couple of weeks. Deb, last closing remarks.
Just thank you for coming to the table. Thank you for bringing the peach cobbler, Keisha. We appreciate it. And we hope to see you on the other side.
Yeah, all right. Everybody have a good, blessed week.
Thank you.
And it's just the way